back. Thank you. Okay, it's me again. So first of all, before I forget, I would like to thank the organizers because I forgot to speak, for the invitation. I'm really sincerely happy to be here. And just a few words about my hospital, which is probably less well known than the Salpêtrière Hospital, but first it's much closer to the Eiffel Tower than the Salpêtrière. And also it looks very nice, so if you come by, please come and visit. So, now I think your brain has worked a lot listening to Damien, so I propose that you relax and I hope you will get a few tricks for your daily practice from my talk that will be focused on neurovascular brain MR. I propose to organize my talk as following. I will, in fact, focus on each of the sequence that composed what we call the stroke MR protocol that we use every day to scan, I would say, 95% of patients. And I'm going to analyze sequence by sequence, trying to explain you which traps you may face and give you some tricks to avoid them. So let's start with the FLAIR sequence. And 3 questions. First, what are the main artifacts on this FLAIR sequence? Because we all use FLAIR, and most of us, we have replaced the classic T2 weighted sequence by the FLAIR sequence. When are these artifacts really a problem, and how can we avoid them? So as you all know, the FLAIR sequence is exquisitely sensitive to everything. That starts with the edema in the brain tissue, and here is an illustration of the cytotoxic or intracellular edema that we see in acute ischemic stroke. It's also highly sensitive to any changes in the CSF content, and that's how we diagnose subarachnoid hemorrhage. Here is an example. So that's the first thing, but anything that will change the content of the CSF will result in a failure to suppress the signal of the CSF. That includes also meningitis, and we should not theoretically be scanning patients with meningitis because we have other tools for this diagnosis. It's also the case when people have hyperoxygenation, and also if they have received some contrast in the past few days and have a breakdown of the blood-brain barrier. David, don't look at me like that. My accent is not as good as yours, but still I keep talking. And the last thing is the FLAIR is very good also to look at vessels. As you know, we can see this, we call that spaghetti or tubular hyperintensity in floating in the CSF that here correspond to slow flow in arteries, and we can also analyze the vein, of course. So all that looks very nice, but the problem is it's very easy if this is a subarachnoid hemorrhage and this is a normal case. In fact, as you probably know, a lot of FLAIR sequence are like this. That means you get this type of artifacts here, just in front of the basilar arteries. These are due to flow artifacts, CSF flow artifacts. And they're not, in fact, they can be problematic, they're not always problematic. They are not really a problem if the patient is referred for a first seizure, for example, because you're looking for a cortical lesion and you don't care if you have marked CSF artifact, flow artifacts. The same here, it's not really a problem because you will simply look at the parenchyma. The second case where they are not problematic is when a patient is suspected of acute ischemic stroke, for example, and here there is no problem. You can make the diagnosis, and it's not because there is a small artifact in the CSF that will be a problem for you. But if the patient has severe sudden headaches, for example, that will be a problem, because if you have such an image, you won't be able to conclude if it's a subarachnoid hemorrhage or not. In such a case, you want to remove these artifacts, or you want to get a FLAIR sequence without any flow artifacts. Typically, the sequence I showed you is a 2D FLAIR sequence that we call the standard acquisition, and it's made, in fact, we apply the inversion pulse at the level of the slice that we are going to image. The problem is that only this slice section is prepared by the pulse inversion, and there are some, because of the CSF flows, there are some spins that are going to move away from this slice. This is not really a problem, because they are running away. The problem is these little spins that will enter the slice and that haven't been prepared, and they are responsible for the CSF flow artifacts that you can see here. So it's quite basic to have a FLAIR without flow artifacts. You simply have to apply the inversion pulse, not only on the slice that you're going to image, but also above and below this slice, so you get a 2D FLAIR without any CSF artifacts. It's a bit longer, takes a bit longer, but it's much easier for your diagnosis if, for example, the patient presents with severe headaches. Another solution is if you have a 3 Tesla and a good machine, you can also use a 3D FLAIR, because the inversion pulse is this time applied on the whole volume, so you have no FLAIR artifacts. But that's, again, a bit longer as well. So if you work properly and you have a FLAIR sequence that's optimized to reduce these CSF flow artifacts, it's very easy to make a diagnosis here of a subarachnoid hemorrhage, either with a 2D FLAIR or a 3D FLAIR sequence, where you can see all these bright signals in the subarachnoid space. Second problem that you may face using FLAIR. The second problem you may face is this type of problem. Again, someone with sudden headaches, and you might have seen such images where you have bright signal surrounding the brain, bright signal in the ventricles. It doesn't look like a subarachnoid hemorrhage because it's suspended. Theoretically, the blood should drop. So the trap is, in fact, that there is a lack of CSF cancellation in case of magnetic field inhomogeneity. And so what you should look in such a case is look at your T2 star images to look for metal artifacts, for example, that will induce this type of images on your FLAIR. That's it for the FLAIR. Now we move to the T2 star weighted sequence. And for example, if the patient is referred with headaches and sudden deficit, one of the traps is to have an MR protocol without T2 star weighted sequence. For example, if you don't have a T2 star weighted sequence, you might miss the diagnosis of hematoma here, which is fairly obvious on the T2 star weighted sequence. Two other examples where you might say something silly if you don't have a T2 star weighted sequence in your protocol. Here, at the acute stage, a patient with an hyperintensity on FLAIR, some funny signal on diffusion weighted imaging, and here it's obvious it's a hematoma, so I think the T2 star weighted sequence is mandatory if the patient has a sudden deficit or headaches. Again, another example here is at the chronic stage, where the FLAIR is unremarkable, and you can see the hematoma, the chronic hematoma on T2 star sequence. So the trick is simply not to forget to put a T2 star weighted, whatever T2 star weighted sequence you want, to search for blood product any time the patient is referred for sudden deficit or headaches. Another trap is, as you all know, I think, the T2 star weighted, and I think it's even worse, I'm sure it's even worse for susceptibility weighted imaging. David said yes, so that must be correct. It overestimates the size and the importance of the bleeding. Here are two examples of patients at the subacute stage. It's the day after, I think 24 hours, maybe after thrombolysis or maybe not. Here you see the massive acute ischemic stroke. There is some type of hemorrhage in the deep middle cerebral artery territory. But I mean, you may think it could be an hematoma or something, a severe bleeding, but look at the scan. I mean, if you look at the CT scan, there is nothing really very important. It's just well, you all understood. I know how to spell it, I don't know how to say it. Pitiki. Okay, so it's small dots of bleeding in the deep MCA territory, nothing to afraid anyone, and especially there is no need to interrupt any anticoagulation if the patient needs it, just because you see this dark, massive dark signal area. It clearly overestimates the bleeding. Another example here, where you probably wouldn't even talk about Pitiki. I'm learning quickly here on this in this second case. Okay, so I talked about the parenchyma on the. Oh, funny, my arrows are funny. I talked about the parenchyma. I'm going, of course, on T2 star. We will also look at arteries and veins, but I think we talked about it a little bit, so I'll be quite quick on that topic. On T2 star sequence, you look at the parenchyma, but probably the most important is the vessels. First, the artery, where you can see the fresh clot here. And if you carefully look at your images, you can see some much more smaller clots. And had I performed some susceptibility weighted imaging, I probably would have seen it better and maybe more clots. If you don't believe me, that's a small clot. Maybe you don't. Look after thrombolysis, it's gone, and there is a small ischemic lesion just facing this small clot. So these are very sensitive to looking for clots. I mean, it doesn't change the patient care anyway, but it looks nice. And the tips is systematic screen the arteries and look for a blooming effect on these sequences. And probably the most important message in practice is the screen at the veins, and that should be part of the systematic screening of any brain MR. Every time you perform a T2 star weighted sequence, you will look for hematoma, but that you won't miss. It's impossible. But you have to look as well as to the veins. And I think I've seen some similar images in the previous talks. Here the veins are hypointense. There is a blooming effect in the cortical veins. I just placed a control subject so you can see with our sequence that we can't see the veins. And there you can make the diagnosis of cortical cerebral venous thrombosis. In case you have any doubts, but I think we don't have any doubts here, you can of course confirm the diagnosis with a post-gadolinium 3D T1 sequence. So the tips, and this is probably the most important message of my talk, is don't forget to look at the veins on T2 star weighted sequence. I haven't finished. Okay, I showed you cortical cerebral venous thrombosis. It's much easier when it's not cortical, when it's the dural venous thrombosis. Here on T2 star, confirmed on 3D post-gadolinium, T1 sequence. And here the control subject, there is confirming the filling defect in this sinus. There are a few traps. If you leave this course and you start looking at all your T2 star weighted sequence at the vertex, it's English, you will maybe face this situation. Okay, this is a cortical venous thrombosis I've shown you before. This is a normal subject. And this is what you might face, quite often in fact, that you may erroneously conclude that it corresponds to CVT. Be careful, all the calcification, the dural calcification in all the patients can mimic a cerebral venous thrombosis. They don't look the same, they are not exactly well delineated like the veins here, but be careful when you look at them, and maybe check the dural wall at the level of the sinus to see that it looks like a calcification and not like a thrombosis. Other traps. It's of course the problem of false cerebral venous thrombosis that we face every day. And I think for that the T2 star is very important because none of these differential diagnoses have a hypointensity on T2 star weighted sequence. Let me illustrate you 3 situations on this slide. You have 2 different patients, one on the left column, one on the right column, and first look at the left column, and here you can recognize Pacchioni granulation, that's correct. Arachnoid granulation of Pacchioni, I don't know how you say that in English, here. And what's important if you have a doubt about a defect or a cerebral venous thrombosis, check the T2 star weighted sequence. It's not dark, so it's not a cerebral venous thrombosis. Second thing, which is a little bit easier, is a hypoplasia of the left dural sinus, which may appear, very often appears bright on FLAIR sequence, and again, it's not dark on T2 weighted sequence. And of course, if you go to proceed to gadolinium injection, it will enhance normally. And the last one is on the other side. This is more tricky, but quite rare in fact. Look at this one. Again, it's, the signal is intermediate on FLAIR, on diffusion. There is no hypointensity on T2 star, so it's not a clot. And there is a defect on post-gadolinium T1 weighted sequence. This one is a bit tricky. It's a herniation of the brain in the sinus. There is no clot here. And just to tell you, look at your T2 star weighted sequence. If it's not dark, it's probably not a cerebral venous thrombosis. Okay, we talked, I'm not going to talk in details about which T2 star weighted sequence we should choose, just to remind you that there is a whole armatorium, well, the panoply, that may be better. Well, all different kinds of T2 star weighted sequence. You can have the classical gradient echo, which may last 50 seconds or 5 minutes. Again, it's not the same if you use a 50-second one or a 5 minutes one. And you can detect some blood product here and here again. This is the same patient imaged by 3 different techniques. This first type of gradient echo T2 star weighted sequence is well suited for example, for stroke patients. The second one is a very quick one. It's an OPI-based gradient echo technique, a few seconds, and it's very good in restless patients. And as you can see, you see the blood product. You see also some tiny modified blood deposit here. It's very efficient, so I think we should use it more often. And the last one that David talked a lot about is the susceptibility weighted imaging. And here is an illustration of angiopathy amyloid. And of course, it's much more sensitive to anything else, but it lasts 3 to 5 minutes. So choose whatever you want, but adapt it to the patient's situation. Okay, a few words again about diffusion-weighted sequence, because I didn't tell you everything before. So, what's left to tell you about this sequence? The first thing is the Harson traps on this sequence. The first one is illustrated by this example. Here is a bright lesion on diffusion. You can see some inhomogeneity here. And the first trap is that you should always check that there is no blood before you analyze and before you conclude that this is an ischemic stroke. This is not an ischemic stroke, this is a hematoma. So first, if you scan acute stroke patient, check the T2 star weighted sequence before looking at your diffusion. It's true for brain hematoma, it's also true for subarachnoid hemorrhage. As you can see here, this is a patient with subarachnoid hemorrhage. It's bright on diffusion, and this is a simple T2 shine-through effect. There is no stroke here, there is no acute ischemic stroke. You simply see the blood in the subarachnoid space that's bright on diffusion. And also the clot can be bright on diffusion. So the tips for the blood products is check that the lesion is not bleeding before you analyze your diffusion images. And here I'll try to convince you to be careful of blood product by this example where we did a big mistake. The situation was the following. We had a CT scan with showing a hemorrhagic lesion. The patient had lost 20 to 15 kilos in 3 months. And we look at the FLAIR. We saw some blood product and some edema. Here is compatible with some blood. We inject gadolinium and we see this massive lesion after gadolinium injection. And we look at the diffusion and we say, okay, that's not bright, it's not hyperintense, so it's not an acute ischemic stroke. In fact, we concluded that was a tumor, the patient was operated, and in fact it was a big ischemic stroke with hemorrhagic transformation. So I think we trusted too much the diffusion to rule out this diagnosis. So be careful, check for the lack of blood before you look at your diffusion-weighted sequence. Don't trust diffusion if the lesion contains blood product. So after this mistake, we tended to drop diffusion every time we saw some blood. So we don't do it, so there is no risk of making a mistake. We don't look at it, we didn't perform it, but it's not the solution because look at this patient. Here you see there is hemorrhagic lesion in the occipital lobe on FLAIR, on T2 star weighted, on post-gadolinium there is no contrast enhancement, and slightly on the slide above you can see also a thalamic lesion here without blood product. And there is not much on the TOF sequence that can help you. In such a case, there is one possibility, is that it's a simple hematoma. There is a second possibility, is that it's an ischemic stroke in the vertebrobasilar artery, and that started bleeding in the occipital lobe. So maybe diffusion can be helpful here. So if you look at the diffusion sequence, that was acquired the next day, because we removed the diffusion from the MR protocol. The next day we see that, okay, it's heterogeneous at the level of the bleeding, not much information. But if you look at the lesion here that's not bleeding, you can read the images safely and conclude that there is indeed an ischemic stroke. So you have the final diagnosis thanks to the diffusion. So the conclusion is that even when there is blood, maybe we should keep doing diffusion because it might still be helpful, especially in areas without blood. Okay, this trap we talked about this morning, analyzing diffusion without computing ADC, that you will fall into the trap of T2 shine-through problem. So don't forget, every time a lesion is bright on FLAIR and bright on diffusion, just compute the ADC to conclude that here it's likely not an acute stroke, it's a glioma, but you need more sequence to conclude that it's a glioma, of course, and here it's an infarction because it's bright and there is a decreased ADC value. Another trap about diffusion is the problem of computing ADC when the lesions are tiny and very small. Here is a case of a TAA patient with symptoms that were on the left side, and we spotted this few tiny hyperintensity matching the clinical symptoms. If you are an addict of ADC maps, you look at the ADC maps, it's normal. So what are you going to do? In such a case, forget the ADC map. The lesions are too small to properly compute an ADC value, and conclude that it's very likely an ischemic lesion. And here is the images acquired the next day that confirm that the lesions are still there, and there is another, this one has included inside, so it's an ischemic stroke. So the tip here is forget looking at the ADC map when the lesions are too small. If you really want to compute ADC, then you will have to run some like so-called high resolution or optimized diffusion sequence. That means to get a better resolution, and if you get a better resolution, then you can compute here for this small tiny lesion, you can compute the ADC. It's more reliable, but only if you have a very high quality diffusion. Another common trap on diffusion is that you might have faced such a case where you have some hyperintensity at the level of the internal capsula, and if the patient presents with a proportional hemiplegia, it will be difficult to conclude if this is anisotropic artifacts or if it's indeed a lacunar stroke. This is a diffusion with 3 diffusion directions in 3 orthogonal directions. So if you want to solve this issue, you just run another diffusion. If you are beside the machine at that time and you see that you will face problem when reading the MR. So just run another diffusion with more diffusion directions, and you will decrease the effect of anisotropy. And here you can safely conclude that there is nothing; it was simply an artifact. So the trick is to increase the number of diffusions in the direction to decrease the anisotropic effect of trace images. If the image disappears, it was an artifact. Other traps that you may face are the following. The first one is quite exceptional unless you work with a stroke unit and you have a hyperacute stroke. First situation is that a normal diffusion does not exclude an acute ischemic stroke, especially when the patient is very early in the magnet. Look at this patient. He was suspected of having a left hyperacute stroke. He gets there before 3 hours from the symptoms onset. There is nothing on the diffusion, it's strictly normal. The MR angiography, it's not very contributive. You can wonder if there is, I don't know what you see on the screen, maybe a doubt about this MCA on the left side, but nothing is sure. So the solution here is you run the MRI. If you have an arterial occlusion, then you have the answer. If not, you should run a perfusion-weighted imaging to try to look for the defect of perfusion that are here superimposed on the diffusion-weighted sequence to highlight you that there was a hypoperfusion, and that you see the patient was not treated because he had a contraindication to thrombolysis, and there is a stroke the next day. So that's the first situation. I think it's 1% of the patients we image, so it's quite rare, but don't trust. If you face a normal diffusion in a patient suspected of having a hyperacute stroke, you should go until the end of the protocol before you decide it's not a stroke. The next situation where a normal diffusion does not exclude an ischemic stroke, of course, is TIA. And as you can see here, I think I've shown you this image before. If you run a normal diffusion, a standard diffusion, and if you run optimized diffusion, then that will be different. You can capture some lesion that with an optimal diffusion sequence that you won't see with a normal one. Some of you may wonder what's an optimized diffusion sequence. In fact, there is many ways to optimize it. You can increase the number of diffusion direction, you can increase the B-value, we talked about this morning. You should increase the number of signal leverage, and of course reduce the slice thickness to have a better resolution. So in fact the easiest way to optimize your diffusion is to set the time that you want to dedicate to that sequence and to optimize it for this set of time. Well, I have two more sequences to talk about, and it will be very quick. First, the 3 time-of-flight MR angiography. And if the patient is referred for a sudden deficit, in fact, using just a simple slab, only one slab, is enough to locate or to diagnose this arterial occlusion. There is no problem. It's probably not enough for patients with sudden headaches. If you run one slab like this, you will, with no problem, diagnose this small aneurysm at the top of the basilar artery. The problem is that you will miss this aneurysm because it's beyond the field of view, and this is the aneurysm that had bled in this patient. So the message here, you might as well miss some aneurysm of the pericallosum artery here. So the message here is every time a patient comes with sudden headaches, you should run 2 slabs and cover from the occipital hole, yes, from the foramen magnum to the top of the corpus callosum to try to cover the lowest aneurysm location and the highest one. A small trick, if you on the 3D time-of-flight images you see such a signal asymmetry, of course, you should look at the cervical arteries to search for a high-grade stenosis that's responsible for this loss of signal and asymmetry. So simply running an MR of the head, you might get information on the stenosis of the cervical head and neck arteries. And the last sequence that we didn't talk about is the T1 weighted sequence on the sagittal plane. I think if you perform a sequence, you must look at it, even if you don't consider that it's important. Because you might have some interesting disease, you might see some interesting things on the midline and on the sagittal T1 sequence. There is 3 things to look at. It's the corpus callosum, the pituitary region, and the foramen magnum. Why is that? The first thing you may see on the midline that you won't see on the other sequence easily is a drop of the tonsil. Well, you see it. A drop of the tonsil and to make the diagnosis of a Chiari disease. So look at it. It's the only way not to miss it is looking at the midline. The second thing that you shouldn't miss is if you have a heterogeneous signal on the pituitary region. Maybe it's not obvious on the slide here, but look at the FLAIR sequence. You have a round-shaped lesion here. It's not far from the Willis circle, so you must think about one thing is an aneurysm. And there is a trick here that you don't even have to run another sequence. Let's say the patient is gone and you haven't done anything else. To diagnose an aneurysm here, you simply have to enlarge the window level and look for flow artifacts in the phase encoding directions that will allow to make the diagnosis of aneurysm without any MR angiography. I'm not saying this patient doesn't need MR angiography, of course. And other things you can find on the midline is this type of lesion. Here it's bright on T1, it's bright on T1 again. It's dark on T2 star-weighted sequence with the sequence we use. It's located at the top of the basilar artery, but on the MR angiography there's not much here. So I let you think for 1 second. So, of course, it's a lipoma. You simply have to do or you don't even need to do it, but if you want to confirm it, you have to run a fat suppressed sequence to see that it's simply grease. But remember, for the youngest of you in the audience, that when you have a bright lesion on the midline, it's more often a lipoma than an aneurysm. So check for the midline systematically. Do not forget aneurysm, but don't think that everything is aneurysm, and think also about simple things such as lipomas that are much more common than aneurysms. And the last message is that if you want to scan the maximum number of, the largest number of patients on MR, you need to design on your machine a protocol for restless patients. Because I've seen too many times people facing a restless patient and trying to make, to adapt the sequence to make it quickly, and by the time you've done it, the patient has left. So I think you should design it and call it restless patient or whatever. And a few tips to do that. First, you should avoid 3D acquisition, because when the patient moves, it's just a disaster. For the TOF imaging, you don't have a choice, it's a 3D sequence. Make it as short as possible. Here in 1 minute, you can get information about the occlusion of the carotid artery, and you get everything you want to know. Think about the EPI sequence, and you can use EPI using FLAIR, T2, T2 star, diffusion. EPI sequence are very useful and very quick. Here is an example of an EPI FLAIR. That was the FLAIR in the patient that was moving, and we wanted to see if there was a bright signal on FLAIR. Well, you get information, but you see it much better on the AP FLAIR. Or you use some dedicated sequence for moving patients, like, they have different names for different vendors, but it doesn't matter. They are quite long, but they correct the motions quite properly, so you choose between EPI or this specially designed sequence, but prepare them before you face the case of a restless patient. So as a conclusion, with dedicated MR protocol, Oula, that was late last night. Okay, with a dedicated MR protocol, that means a T2 star weighted sequence, whatever you want, susceptibility or basic ones, but everywhere in every protocol. For patients with headaches, I think you should optimize your FLAIR, either 3D or optimize without the 2D, without CSF artifact. I showed you how to do it. Use optimized diffusion when necessary, for example, for TIA patients. For MR angiography, use a small coverage for acute stroke patients, but a much larger coverage for patients suspected of aneurysm, and think about the restless patients. And for the reading, systematically screen the veins, especially on T2 star weighted sequence. Check the ADC if there is a hyperintensity on T2, and don't forget the midline, and I think you will avoid all the traps. Thanks.